No.
Good morning, everyone. We're a couple of minutes late, so I think we'd better make a start. Yeah. Firstly, thank you very much for being here today. We are the people who are not on summer holiday yet, so it's nice to have as many people as we do. So thank you. My name is Councillor Susan Van de Ven. I'm the Cambridgeshire County Council lead on as one of the co-chairs of this meeting. And you'll know John O'Brien, chair of the ICB, who is the second co-chair. And then we also have Peterborough City Council lead as our third co-chair and in a bit of a transition. So I'm not sure if we have Councillor David over here yet today, but I think we're expecting him. Oh, sorry, apologies, but next time. Before I start, I wanted to just record thanks to Councillor John Howard of Peterborough, who's been the co-chair with John and me for the past year. And I think it's fair to say John was very much part of the collaborative approach to this meeting, and would really like to thank him for his contributions. Right, we will take item 1. Whoops, I'm on the right one. I have to start reading the formal script. Sorry. So I'd like to begin by welcoming everyone to this meeting of the joint Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership at New Shire Hall. Filming and photography are allowed at this meeting, so please feel free to take pictures and to use social media during the meeting. Can I ask, though, that everyone present turns their mobile phones to silent or vibrate while the meeting is taking place? Please be aware that this meeting is being live streamed and that a recording of the meeting will be available to view on the County Council's website. There is no fire alarm test scheduled for today, so if the alarm sounds, please leave by the nearest marked fire exit and assemble in the car park. The closest fire escape is through the middle doors on my left, past the WC in the kitchen. Apologies and declarations of interest. Would the head of governance and data protection please report any apologies for absence?
Thank you, Chair. We have apologies for absence from Councillor Lynn Ayres, with Councillor Jackie Allen attending as a substitute. We've had apologies from Jed Curran, ICB non-executive member, Kit Connick, ICB Chief Officer Strategy and Partnerships, the Police and Crime Commissioner with Jim Haylett attending as a substitute, Dr. Nick Johnson, Mayor of Cambridge and Peterborough Combined Authority, with David Packett attending as his substitute, Louis Camphor, ICB Deputy Chief Executive, Winese Purry attending as his substitute, Dr. Neil Moder, Primary Care Representative North, sends his apologies, Liz Watts, Chief Executive South Cambs and District Council Representative South, sends her apologies as well. And we also have apologies from Eileen Milner, Chair of Cambridgeshire and Peterborough NHS Foundation Trust.
Thank you very much. Next is declarations of interest. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? No? Okay. Next, we're being asked to approve the minutes of our meeting on the 24th of March as an accurate record. If any board member wants to raise a question on the accuracy of the minutes only, please can they do so now? No, I see no objections, so we'll take that as carried unanimously. And just before we go to item 3, I wanted to just acknowledge that we had an excellent, very well attended development session of this group on the 6th of June, and we're tending to do that between our formal meetings. And this has been enormously helpful in order to have a chance to kind of brainstorm and discuss things informally and to prepare for our next meeting. So that was much appreciated. Right. The next item is the first full item is the item 3, the Health and Wellbeing Board report. Sorry, Health and Wellbeing Board and Integrated Care Partnership annual report for council, and that will be for Cambridgeshire and Peterborough councils. Could I ask Jyoti Attri, the Director of Public Health, to introduce this item? Thanks.
Thank you very much. We've continued in the vein that we've started on this report, in that we've produced this together across the system, the ICP and the Health and Wellbeing Board. The reason we've produced the report is because we're required by statute to bring an annual report to both full councils. So that's the purpose of it. But we have continued in the vein that we've always worked around this table. So that's really good. There's nothing new here, of course. It's an annual report recording the work that we've achieved together over the last year. It spells out the progress that we've made on in the engagement agenda, the Let's Talk agenda that was largely led by the ICP. And then the progress we've made together on the health and wellbeing strategy, the joint forward plan, the pharmaceutical needs assessment, and the Better Care Fund. So it's really just recording the progress that we've made over the last year. I would like to thank Kate Parker and Kit Connick and colleagues for their hard work in pulling this together. And I'm happy to take any questions. Thank you.
Thank you, Jyoti. Are there any questions? Gosh, no. Okay. Well, over to Councillor Howitt.
You're not allowed to call me Richard, sorry. My only thought in the input we gave beforehand was that a lot of this is about strategies and meetings and institutional stuff, and it's all absolutely correct and fine and important to report. But it's, I think for members of the councils who are not following it closely, I think it needs something to make it more human and what the real impact is in human terms. I just wonder whether the 3 co-chairs could do a forward to it or something. I don't know if that's possible under whatever rules, Jyoti, but just something to give a flavour of our discussions near the start, I thought might improve this.
I would say there are some case studies through the chair. There are some case studies in the back of the report that do bring it to life and show the human impact. I'd take Kate or Democratic Services advice on whether I'm sure the chairs could do a forward. Yeah, that's great. Thank you.
Great, thank you. Actually, I did want to note a couple of very local examples of where I think the strategy has made an impact. And one of them is on page 1213 is the Free to Feed campaign, which was very strongly advocated and facilitated by the district councils. I noticed in South Cambridgeshire, there was a strong Free to Feed campaign on trains. And a very could make a very kind of vibrant group of young parents with their children, feeding their babies from Cambridge to Shepparth, and then getting off and going to Shepparth Wildlife Park, and then feeding them some more, and then going home. And that was very well publicized, and I think it sent a really strong message that you really are free to feed your baby wherever you need to do so. And if I may say also, I thought that showed that our district councils are really important players in being able to reach down to kind of street level. And I know Paul Med from Finland District Council is here today, so wanted to just say that while you're here, and I'm sorry that Liz Watts isn't here because I know she played a part in helping that project along. So the more of that, the better. And I also wanted to note the acknowledgement of uncertainties in the pharmaceutical needs assessment. I think some things have changed, haven't they, since we did the assessment? I don't know if you wanted to comment on that.
Yeah, that's right. I think it was Lloyd's Pharmacies have withdrawn their services. So we're currently considering whether we can just do an amendment to that. I don't think my personal views, I don't think it warrants pulling a pharmaceutical needs assessment together is an awful lot of work. There are mitigations being put in place. So many of the pharmacies are being taken on by other providers. So I think once the dust has settled and we understand the full impact, we can then assess what we need to do with the P&A.
Thank you for that. Paul Med?
Thank you, Chairman. So I think the first point to note is that it's great to see the progress that we've made over the course of the past nearly 12 months. I think whilst recognising that there's still many challenges ahead of us and much still to do, I just wonder if future versions of this report might be enhanced by incorporating some narrative about what's going on specifically within the North and South Place partnerships.
Thank you for that. I'm sure Jyoti, I'll hand that over to you.
I think we'd need to consider, I mean, this is a report of the Health and Wellbeing Board, not the two places. We'd need to consider how we'd work that in if we were to do that in the future.
Julie, oh, sorry, Paul, did you want to just come back on that?
Just really quickly, I think just to sort of further add, recognising the work that's been done in the North and South and how that contributes towards the overall objectives that exist within the kind of the system as a whole. So I just feel not a great deal of detail, but just an overview to give a sense of those local interventions and how they're contributing towards, if you like, the strategic objectives that are captured within this annual report might be helpful.
Mm-hmm.
Okay, great. Yeah.
Great. Thanks. Julie Farrow.
Thank you. Sorry, I'm going to go back to the pharmacy piece, if you don't mind. I was at a meeting yesterday where the regional pharmacy rep was talking about the changing contract and therefore the reduction in hours, in opening hours of pharmacies, that is going to dramatically impact on our communities. And I wonder whether that has an impact on, you know, the well-being of our communities. So if you're not able to access a pharmacy when actually people are being told to go and get more help from pharmacists to actually save the health system in certain points, what are we going to do revolving around that? So I think that actually for me that was a really big issue, because voluntary sector have been pushing to actually get people and recognize to go to pharmacies as a place that they'll be able to get adequate support and help. And I just wonder whether we do need to think about what our response is going to be and how we're going to track that in future.
Thank you, Julie. Stuart Farrow.
Yeah, could I follow up Julie's point, because it strikes us at Health Watch that there seems to be a complete disconnect between what the government are saying about what pharmacies and how, you know, you can pop down to your pharmacies and get everything sorted out, and you speak to GPs and they say it's a nonsense, you can't, and you know, personal experience and the people I speak to, so you simply can't. So there is some sort of communications gap here by this constant, you know, go down to your pharmacy and everything will be fine from the government, and then when you get there you can't buy some cream for your spots because they've got some antibiotic in it. So there does seem to be a communication gap there somewhere. Sorry, I thought I'd just register that.
Thank you. James Morrow.
Thank you, Chair. And following on the pharmacy point, it's reported that under the current pharmacy national contract, some 60% of community pharmacies are now loss-making. So there is a inherent financial instability within the community pharmacy sector. Following on from Stuart's point, our community pharmacists are a vital part of the network of healthcare professionals delivering and enabling home care, self-care, and taking activity away from the formal health sector, which is very much helping with the current pressures that we're feeling across the board. So I very much welcome the attention of this board on the sustainability, nurturing and support of community pharmacies, not only as a vital infrastructure element, but also as a vital part of the delivery of healthcare and the totally justifiable and necessary rationale for enabling people to manage their health by themselves with professional support as much as possible without formally entering the health sector through GP surgeries, accident and emergency or walk-in centres.
Jyoti, did you want to respond?
I'm not sure that's entirely for me. It might be that Jan wants to come in. It's a product of both the national contract and what we can do locally to improve services. And it's not entirely in our local gift, I think. I don't know if you want to make a comment.
So yeah, there is huge pressure on local pharmacies at the moment. We're seeing community pharmacies, as James says, very much struggling. We're also seeing national chains withdrawing from the market at quite a rate. So that tells us there's something fundamentally wrong when it's not just the little guys that are struggling, it's the big chains as well. I think there is still a big opportunity, and in the coming weeks, I think we have got plans, and we have been in contact with the local pharmacy committee to talk to them about how we help them be more sustainable, and we can report back on that if that's helpful in the future meetings.
Thank you for that. I don't know when we next do the pharmaceutical needs, but it will be in a few months, won't it?
The P&As are done every 3 years. That's the programme of the P&As, but we're considering whether we need to make an update based on the current situation.
It sounds like there would be support for doing that. Richard, are you? Yep.
The only thing I'd say is this, so what I hear from Jyoti is that it's quite a large exercise to do a whole assessment. And I wonder if there's a sort of midway suggestion, though it's quite proper, and I'd share the questions, let's say, that have been raised today about the current situation, but is there a way of us looking at that and trying to respond to it without necessarily going through the whole exercise again?
That's exactly what we're
that in.
Sorry, that's exactly what we're considering, Richard. Yeah.
Good, but we can work that into our forward plan, our forward agenda plan. Okay, and I think the final thing to say is a very big thank you to the people who put the report together. Oh, Patrick, sorry.
Yeah, thanks, Chair. And good morning, everybody. I'm Patrick Warren-Higgs. I'm the Exec Director for Adults Health and Commissioning at Cambridgeshire. And it's my first Health and Wellbeing Board, so I'm pleased to be here. And I'm into week 6 at the moment, the end of week 6. So I'm still finding my feet. I just wonder, back to Paul's point, really, I just wonder if the report could really pull out whether the priorities are targeting the right parts of the county to see some real difference. And it might be that's in the detail, but we could be celebrating that actually we're addressing our priorities, but are we addressing the priorities in where it's of greatest need? And I don't know whether or not that's in some other papers that I've not yet reached, but I just wonder if the annual report needs to pull that out to really recognise that we are making a difference in the right areas.
So you've probably missed a few papers and meetings to be on the same page with us. We're predominantly going for a universal first approach, and then targeting on top of that and using behavioural insights to really support us to target in a scientific, more meaningful way, rather than pure geographical targeting, which doesn't necessarily work and often If you target the poorest area, for example, you miss the majority of individuals who could benefit. But I'm happy to bring you up to speed outside of meetings.
Thank you for that. I think that falls under the flavor of the evidence too locally and what we're actually seeing. And apologies for not welcoming you at the start, Patrick. I have my reading glasses, not my driving glasses on. So, okay. Sorry? We'll talk about that after the meeting. Okay. So I think, do we have to say anything? So I take it the board is happy to support the recommendation that we, what are we doing? Oh, right. Thanks. So we have been requested to review and comment on the annual report before its submission to both local authority full council meetings in October 2003. Thank you very much for the discussion. And I think the board is happy to support this recommendation unanimously. Great. Okay. This is the, this is printed. We're now on item 4, which is the the health and well-being ICS strategy priority 2, although I don't think we're not doing them in order. We're starting with number 2, aren't we? We're focusing at each meeting on one of our 4 priorities. And this is our sort of kickoff to really look at one of our priorities in detail. And today we're looking at obesity, the obesity action plan. And so we have a very interesting report, which Val Thomas, Deputy Director of Public Health, is going to introduce. Thank you.
So actually, Susan, I'm going to introduce.
Oh,
and
I'm not reading the script.
That's
okay. You can
okay.
see I've lost my page.
So you recall that both Louis Camphor and I are the senior responsible officers for this, and both of us have stayed very close to this as it's developed. And it is very much a partnership, system-wide approach to tackling obesity. That first slide acts as a reminder of the complexity of the system, and that no single action in any one of those blobs, circles, ovals. We normally deal in triangles in public health, so this is confusing me. Will make the impact that we want to make. We'll move on to the next slide, please. Okay. So again, this is a reminder of the approach. So Patrick, this kind of outlines the fact that we are going for a universal first approach supported by targeting to meet the needs of different populations. And that targeting will very much be informed by our behavioural insights work that we're undertaking. We want this to be about a system-wide change. So that will mean not just the delivery of services to individuals, but more about tackling the policy environment, the physical environment, and the many opportunities there are to influence the system to impact on healthier behaviours. And we want to absolutely learn from the established evidence base around this and add to that through our behavioural insights work, which we hope will inform the targeted interventions that we want to take. So a big focus on early years, as we'd all agreed, children first all the way through this, and tackling obesity through schools, because that's where we can reach most children in line with our universal approach first. We're undertaking a food survey, and Val will report back on that in schools to understand the current baseline in terms of provision, and then using that to inform further interventions. And then incorporating physical activity both into the school day, but also through active travel. As we've talked about, the targeted part of this will be through our behavioural insights research, which we're in the process of commissioning. And when we get the outputs of that, that will hopefully give some direction about what we do. So that will be very much about understanding the motivating factors and the barriers to people's behaviours, and then addressing our interventions around those. And then finally working with the health service to get a better measure of weight, adult population. You know, we've got a brilliant measure of children through the NCP, really sound measures of obesity in childhood. Mainly focused in primary care. There's a gap around secondary care, so we don't really know what happens, you know, to kids and how obesity increases, or probably increases. It's not going to be decreasing in secondary care aged children, so that is a bit of a gap. But also our information about our adult population is dependent on surveys and, you know, the sampling of the population. So getting a better measure in primary care is important, both for establishing our baseline and really understanding the size of the problem. It's hard to do this without puns either. But also to identify individuals who need further support and could be referred on for intervention. So it's important for both of those reasons, and we're working closely with Louis and colleagues to improve that. And then, you know, making sure we apply the evidence base and improve the entirety of the pathway, and also understand the driving factors such as mental health and the wider determinants and their impact on weight management. On to the next one, please. So we had previously looked at some targets. I think it might have been in a development session, and the steer we got from this board was stretch, you know, really be ambitious with your targets, but have them grounded in some level of realism and an ability to actually deliver against them. These are all still, in the current context of increasing obesity, very, very ambitious targets. And actually, Anise asked me yesterday, are you confident we can achieve these? And the answer is no. You know, we've deliberately gone for stretch targets, and we'll keep challenging ourselves to say, well, you know, what else can we do? What more can we do? How can we do things differently to achieve these targets? So, you know, they are, and I've always requested that you don't use these as a stick to beat us with. You know, we've deliberately been ambitious with these. We've made some amendments to these in terms of the physical activity targets that we had before, because I think we'd gone for all children achieve their recommended levels, and all adults do. When we reflected, that's not achievable at all. So these are still stretch targets, so 20% for children and 10% for adults, but are you know, grounded in some level of realism and deliverability. So I'll stop there and hand over to Val. And I would again like to thank Val and other people across the system who've supported Val in making astounding progress, I would say. You know, she's just really moved this agenda on at such a pace, as you'll hear now. Thank you.
Thank you, Jyoti. I'll now try and give a sort of more granular insight to the overview which Jyoti has just provided. This, for those of you who like logic models, this is kind of a logic model, but not a logic model, but it lays out what we've been doing in the past 6 to 9 months, with the ambition at the end to produce a set of interventions. Some of those we've started, but also very much to have a sort of plan for the future that's based on evidence. So in more detail, we've done Jyoti's referred to the importance of the environment and behaviours. I think if it was easy, we wouldn't be where we are at the moment, with 64% of the population either obese or overweight. And so many things have been tried. So I think what we've been doing in the past 6 to 8 months, let's drill down and try and understand more in terms of what are the barriers and motivators. So we've done various actions, quite a comprehensive evidence review of the environmental factors that influence people. So that might be, for example, food in schools and hospitals, the options that they have and how they influence people's behaviours. Secondly, Jyoti's mentioned the behaviour science research, and this, hopefully, yesterday we completed the procurement, the moderation. So next week we'll be able to announce the successful bidder for that. And we had a good number of bidders, ranging from academia through to the commercial sector. And I think this will really help us understand there's a certain assumption that we know why people do certain things, but behaviors aren't like that. They're complex. So it's really drilling down and getting that understanding. Alongside that, our behaviour change services are up for we'll need a new service in 2025. And this again provides a very good opportunity to look at how we deliver those services, which can be informed by the behavioural science research. And I think that's quite critical because the whole landscape has changed in the system as well. So having the understanding of those motivators and how they play out across a new system, I think will give us a lot of opportunity. We've also undertaken a school food survey, and I will come back as a last challenge slide, in fact. There is a focus on children and young people, and we commissioned a survey which was across primary and secondary, though we did have a better response from primary school, which probably for obvious reasons. And there were some key findings in that about the pressures in schools which act as barriers effectively, and I'll pick up on that later on. Then thirdly, it's working with the NHS, particularly around those obesity-related clinical risk factors. And we've focused very much broadly around CVD prevention, but also the importance of GPs. 74% of people will attend their GP at least once during a year. So they are really important gatekeepers here. They important access, and we can provide this firstly with a lot of data about what actually is the level of obesity in our adult population, but also enable us to put in interventions that can address those complications of obesity like high blood pressure and high cholesterol. Alongside that, other interventions like expanding the NHS health checks program, which has quite a strong obesity factor. And this is in the context as well of the NHS Forward Plan, which gives a lot of support for addressing obesity and risk factors. So it is the interventions we've focused on in the past 6 to 8 months have been very, very system-wide. The other part of that is the engaging, very important in terms of that first slide, which shows the complexity of obesity and the scale of support that we need from across the system. We haven't gone for creating an immediate group, but more identifying those key organisations that can play a very powerful role in taking the agenda forward. We've looked at how the role of incentives in taking work forward, and then, which I'll talk to in a moment as well, and then a planned summit in the autumn, which will bring together that engagement. I'll come back to that as well. But we have been doing some other things in the year. We've expanded our active travel programs in the local authority. We're about to introduce in September a school-based innovation fund for physical activity, whereby schools can bid to introduce new schemes, which have to be evaluated. And then if they evaluate well, and if they can be maintained, there is an incentive payment. And we've also, on the other side of it, we have expanded our services more than the management of overweight and obesity. And we've commissioned additional adult weight management services, and that will start in September. And we are currently, we've almost finished commissioning children's weight management services, which is quite a relook at children's weight management services. And it looks at prevention through to supporting more families with more complex issues. And alongside that, the ICB has been, or ICS has been working with low-calorie diets pilots and new drug therapies. And just to say, I think that all of these, is a relationship. If we are identifying more people and if we are putting in more prevention programs, these services need to be able to actually do something. So it's kind of circular and having the capacity to respond. Also planned, public sector has probably the largest workforce in the, not just here, but everywhere, in fact. And it's something about leading by example. So what support can public sector workplaces provide for weight management to support their staff? We've looked at the NHS food environment and some of the fast food options that are available. Again, it's leading by example. And then in the autumn, I mentioned the autumn summit. And it's where we would bring together the evidence and the information that we've been collecting with our Cambridgeshire particularly is fortunate in the number of academics that we have in the field. But nationally, we want to bring together our local and national academics along with our local leaders to look at what the evidence is telling us. And based on that and what experts are saying, develop our plan that can be rolled out over the next couple of years. So all this does present a lot of challenges. And here I put what we think would be our immediate priorities that we would require board and system-wide support. The built and food environments, the evidence says, are phenomenally influential, but they're complex. They are tied up in local policies, local planning authorities. There's a long, I think, local plans are renewed every 12 years, so there are windows of opportunity. We think that's an area where I think presents some challenges. I've mentioned about on-site access for public sector staff to services that will support them with both the prevention and also their management of their weight. I mentioned about the need for active primary care engagement, given the influence that primary care can have in terms of access to people who at an early stage, but also particularly who have obesity-related conditions. There are policies in changing policies in schools, for examples, and food concourses that I've mentioned earlier, all present policy challenges, excuse me. And then there's the interdependencies across priorities. This priority sort of fits in probably into all four priorities, as the other priorities. It also, the interconnectivity between the four of them is immense, but we're all at different stages. So it's being sure that we embed appropriately into those other priorities, particularly in those areas where we need that support. So the obvious one is in the children's priority. And then I think system-wide issues, undoubtedly in terms of the cost of living and inflation has had an effect on people's diet and their ability to make choices. And the other big issue is workforce capacity, which again puts another stress on taking forward so many agendas. And finally, I think in the autumn summit, we really want commitment from system leaders to take part in that summit. And so it's a real opportunity to agree at our priority areas for taking forward. And just as an example of the challenge, the school food survey threw up some interesting things. Generally in schools, there's a commitment that policies reflect what we would call the healthy school standards, they're national standards, and they are nutritionally sound. And there's a commitment to a whole school approach, but there are challenges. The academic pressures of catch-up post-COVID means that there's shorter lunch times and there's less time, less focus. So they have to be very quick. So it's that sort of fast food ethos. The external food environment, the fast food outlets that surround schools, particularly for secondary schools, that becomes a risk. But there's also the financial pressures upon schools to provide reasonable, healthy, nutritious school meals. Not to put in vending machines is a cost to schools. And it was a clear theme in the survey results that schools feel these pressures and find it incredibly challenging. There is that sort of call for support for investing in school meals. School meals for many children is only access to a healthy food during the day. There's suggestions around how can we make school meals cheaper, and we did benchmark the cost of a school meal across Cambridge and Peterborough to other areas, and we are sort of midway, which suggests it could be done more cheaply. And with kind of another recommendation, therefore, should we be looking at that, look at the best catering options, how schools can work together, other suggestions which are detailed there. And of course, the external food environments and the planning authority issue. And I think it's always good to flag up, I think, that we have, 4,600 school children who are entitled to school meals and don't take them up. And probably I saying this to Joy the other day, and she said, well, what are we going to do about it? One of our main barriers is that in terms of targeting information, there's a huge data issue about accessing information about families who are not accessing school meals, which they're entitled to. And that more or less sits, that's more with the benefit system where the blocker is, but that shows the complexity and how we need support across the system. And I put it in as an example of some of the scale of the challenge that confronts us. And that's the end of the presentation.
Thank you very much. There's an awful lot to think about. Could I first ask if anyone would like to ask a question or make a comment? Piers.
Yeah, thank you, Chair, and really well done to the two of you. This is incredibly important work. I'm thinking more about adults here than children for the moment, but and I know, Jetty, we're supporting you with some of this in our team, but it's as much about how you configure the services as how you identify the population and the different types of thing that you're going to offer them. And at the moment, we commission adult services tier 1, tier 2, tier 3. There are pretty strict referral criteria by which you go into one of those. Lots of correspondence between, for example, primary care and the acute trust as to whether you refer somebody into this. There are some quite significant thresholds about whether your BMI is actually enough to go into tier 2 or tier 3. And as we go into the summit, I wonder whether we could think about having a much more integrated service where someone who knows that they've got an issue or who's identified by their GP as having an issue, or perhaps they come onto this because they've got a cardiovascular condition, can be offered a whole package of things that they can move up and down. So, you know, the sort of least end, you've got weight loss clinics, you've then got some of the apps that we're seeing used in Scandinavia to help manage your weight, then potentially getting onto semaglutide. So you go up and down. And maybe something like a single point of access for both, either for patients or for clinicians, just to make all this easier, because the way the services are currently set up, I think, doesn't help in the objectives which we've got, which are very much around the sort of public health, population health agenda. So I think how the services are designed as we go into an autumn summit is at least as important as, you know, we know a lot of the interventions that work. We know where the evidence is, but how can we get this actually working better? And you touched on that, but I think that's really important.
Yeah. You want me to I'll wait until the end.
Why don't you go for it?
Okay. I would fully agree having that approach would be ideal. And we just commissioned an additional tier 3 service because of demand. And we do have a central triage, which will pull, and we're doing the same with the children, having a central triage. But I think there are more opportunities to link to other services. And I think it goes back to what I said about we have to recommission in 2025. And I think there's a real opportunity in terms of the system landscape has changed. So how do we make services work best for people in that changed landscape and best meet their needs?
Paul Med.
Yeah, thank you. So I think first thing to say is thanks to Jyoti and Val. It's such an important priority, so it's good to be reminded of what our priorities and targets are. I think 2 points from me is when we like to see some information come forward in respect of outcome metrics to give us a sense of how we're doing and the direction of travel. So that's the first point. I note with interest reference to local plans. So certainly councils, I'm sure, will be more than happy to support a conversation around local plans, how they evolve, particularly around the built and food environment. I think, speaking pragmatically, we would need some support from public health colleagues to engage with our local politicians, because often there is a tension between local economic priorities and public health outcomes. So I don't believe it's impossible to reconcile those tensions, but it is a challenging issue that, you know, we would need some support from public health to reach out and engage with our elected representatives.
Are you just going to say yes? Good. Thank you very much. I was wanting to ask that question myself. So
Absolutely. I mean, that's one of the things that's on our agenda to strengthen is our relationship with districts, because we recognise how many of the levers they hold around this. And I absolutely agree with you, Paul. These are not irreconcilable tensions.
Thank you. Anis Pari.
Thank you, Chair. I'm Anis Pari. I'm the Deputy Managing Director of Strategic Commissioning in the ICB. I'm deputizing for Louis Camphor. It's my second week, so I'm absolutely delighted and excited to be here. One thing I can note is how the ICB and the local authority has prioritized and working together strongly towards a systems approach to address obesity. I'm delighted to know that. So I've come from a regional perspective. I do have, in my previous role, I do have an oversight. I did have an oversight of all the other ICBs. So this is really refreshing. I've got 2 points which I would like colleagues in the room to actually pay attention to and also commit to in line with what Val has said and what Jyoti has already highlighted. I think the first thing is this is a complex and wicked challenge. Our targets are very ambitious, absolutely, but we need to be ambitious about that. There are lots of moving parts. We will make mistakes, but we need to learn from our mistakes and move on. So we need to iterate, the first bit. So evaluation, the role of evaluation is absolutely important, including new models of care. And the people over here, we need to be committed to those resources from the very start of our journey, not as an afterthought, the first bit. The second bit, given the privilege I just had coming from a regional perspective and seeing what the other services are across the ICBs, one of the things which I do notice in the system is, and again, we are far away from where we want to be, but just in terms of one of the councillors raised about outcomes, we are doing well in terms of digital weight management. We are one of the best performing ICBs across the 6 ICBs in the region. It's about hope that we can get there. We are far away from where we are, but just wanted to kind of raise that as well. Thank you.
Thank you very much and welcome. Are you content if I think I have John, Jan, and then Stuart, James, and Richard. So if we, guessing, is that all right if we go first to you two?
Thanks, Susan, and echo thanks of others to all those, Val, Jyoti, Louis, and others who've been working on this. I had a particular question about the behavioural insights research, and I know, Val, you were saying more will be public next week, but just in terms of what we think we'll get from that and when and what that will inform. So I don't know, do we think that's something which we could use as part of the summit in the autumn, and how will it potentially, of course, it could shape the programme and the strategy and such things. I just wanted to get a little bit more flesh on that, if I may.
I think there's it's very much about, as I said before, about understanding why a person behaves in a certain way and what those environmental factors which drive a person and what behavioral factors, but obviously they're entwined. Your behavior is influenced by the environment. And I think there's a kind of a misbelief that this is all about, we do a campaign on the back of that. It's much more than that. It's how we shape our services. And so that, if a person, in terms of prevention, it's sort of understanding, what would change a person's behavior, what would make it easier for them. And I've learned a lot in the course of the procurement, in fact, because we've had some academics on the evaluation, and their explanations of the different frameworks really shows you how granular the analysis can be. And how complex and how challenging it is to use the information. But what the frameworks do, they drill it down into something that can resonate with you in terms of how we develop with how services are developed and campaigns. I'm not a great fan of campaigns, I must admit, but in terms of services, and that's I think would play into the summit in terms of the policies of which it can feed into, in terms of understanding which policies would be most influential. How we shape our services, which comes back to that thing about the question just now about how we fit in, how we integrate our services in a better way, and what service users want out of an integrated service. In terms of timeline, I would like to get them going. It's not something where they need a long lead in. All the bidders have an established program in place. They have their academics in place. They have their researchers in place. But it will take, whatever topic we choose, first of all, will take a few months. So we might not have the full information relating to diet or physical activity, for example, in time for the summit. But I think we would have something, and I think we would have the academics there from other areas, the experts in behavioural insights research that could also feed into this as well. So it's kind of, we'll need another summit, I think, when we finish the research. I think it would be an iterative process, I think.
Thanks, Jan.
Thank you, Chair. So, I guess, I mean, it's a really good start, isn't it? It's really good, ambitious, and there's lots of work going on. I guess, and taking into what Val's just said, there is not liking campaigns. My question is, around this table, we've got every layer of support for individuals in our system, and I just feel like saying, is this really enough? And actually, should we be looking at an obesity pledge, really, not just for every not just to take this as a strategy, but how we are taking this into account in every decision we are making. So, and I mean that through everything from planning permission, to use of premises, to vending machines, to green spaces. How is this going to be weaved through every decision we make? Because I'm a little bit skeptical, knowing the pressure the NHS is under, if we think that sending more work to the GPs, putting in more services, I'm a little bit skeptical that more services will get us out of this, especially knowing what pressure the GP practices are under at the moment. And we see that, and we've talked about pharmacies. So my question is almost the reverse, which is, if the NHS, I'll be careful how I say this, because I'm going to be quoted as saying the NHS shouldn't exist, which I'm not saying, just for absolute clarity. But if the NHS and the GPs weren't so heavily relied on in this model, how would we go to where people live their lives, not relying on people coming to health services for support? So one, are we all as a board willing to commit to a bigger pledge on this? Is it weaved through everything we're doing? And how would we weave this through every decision that we make, rather than seeing it as a programme to the side?
Thanks. The list is getting longer, so we need to give this.
Can I just comment on that a moment?
Yeah.
Please? Because I think, Jan, with your team, we have been talking about a pledge, and that's exactly where we've had that discussion with Simon and his team. So I think that's one of the ambitions, to raise the profile, essentially, with all our organisations. So I think that is something which has been in discussion.
Okay. You can tell. You want to come back? Yeah.
Can I just come back on that? So we're all here now, and I think there is something about us as a board when we're agreeing these papers, isn't there? Us going and so what does this mean I'm going to do tomorrow, as well as just reading the papers? So I think it's in that context I'm raising it, Val. I know that work is going on, but I think for us, when we're making decisions, everything from, as I said, planning to buses to services to everything, how are we all willing to think about how we weave this through?
Well, I'll use my opportunity to say, I hope we're going to talk some more about schools, because we're meant really to have a focus on children and in the earliest years. So, but I'll come in again after everybody else. Stuart.
Thank you, Chair. Thanks for the report. And just say I agree entirely with what Jan has just said. And it was a point I was starting to make, but I'll make it from a different direction, if I may. And that is actually how joined up are we? some of the points that you made, particularly about education, Chair. I mean, it's interesting that in Peterborough, I think virtually every secondary school has more than 1,000 pupils, some far greater than that. And their lunch times vary from half an hour to an hour and a quarter. And I don't know why that is. I mean, there may be infrastructure reasons why that's the case, but I just find that interesting in the light of what you've said. So the point of asking the question, how joined up are we, is that I am presuming that education directors at local authorities are very much involved in this. I find the 4,600 children who do not take up free school meal figure frightening. Now, I know that every one of those 4,600 children are not living in poverty, but an awful lot of them are. So why is that? Is it because there is a group within society that find it difficult to fill out the forms, that schools don't have enough time to do that, although they'd welcome the additional pupil premium funding? But there's got to be reasons in that. And that does strike me as a pocket. I know the overall approach, but it's a pocket that one could actually work quite hard on. And my final point is, what role do social prescribers have in all this? Because we've seen the development of social prescribers over the years. I'm not sure that that's been developed quite to where it should be at the present time, but I would think they're quite important within this, aren't they?
Val, do you want to come back real quick? Because I think we have to actually watch the time as well.
Yeah, I think the issue around the data, it's a long-standing issue, and it's a discussion between, you know, the local authorities, DWP, because DWP essentially own the data, and it's something that it's an ongoing challenge, and it's raised to national level on regularly. I think we can do, you know, it's so much better to be able to target a family than just put out the messages and things like that. And perhaps if they need help with, you know, actually applying for school meals, and schools do make it as easy as possible. But at the end of the day, it's understanding why people aren't taking up school meals, but we don't know who the people are that don't take up the school meals. And it's one of those wonderful data blocks, I'm afraid.
Jyoti, did you want to come in there?
I did want to come in. I think it's almost one of the most important issues that we're trying to tackle here. So there's the issue of getting individual level data that we're struggling with, but also there are infrastructure issues behind this, and Val's survey has revealed that, for example, if we were to introduce free school meals universally, schools could not cope with that. You know, we don't currently have the money to do that, just to clarify, but, you know, there is a trial in London that's happening. This could be rolled out nationally, and the infrastructure issues need to be tackled first before that can actually be implemented. And having looked at uptake of free school meals in a previous role, actually it's simple things like kids don't take them up because they want to sit with their friends who brought in packed lunches, or, you know, just little things like that could, if they could just sit and eat together, could be resolved, and we could increase free school meal uptake very quickly.
Could I just ask whether at the summit, in addition to County Council education lead, we will be inviting Academy Trust leaders who will be so closely involved with budgetary issues around what sort of food is provided, is on offer at schools in order to make their own case.
We want to have a representative.
Yeah. Okay. Thank you. We have.
Could I just make one more point on that?
Yeah.
The quality of school food is also really important, and I think there are issues around the quality, and I think driving down the cost maybe isn't the answer, or, you know, to do it more cost effectively might be the answer. But also, if we're going to drive up uptake of school meals, it needs to be good quality. Otherwise, why are we doing it?
I think schools are committed to it, but they just can't afford it. if you look at the policies, and that's what they're saying. That's the feedback.
Anis.
I'm really sorry, but just following on from Jan's challenge to everybody in this room, can I request the chair to request the board to commit ourselves towards the pledge, at least by the summit, on what each organization is going to commit doing in terms of the role as an anchor institution, but also as part of the BAU, what and how? That will be really helpful. I think this was a powerful question, powerful challenge. We need to commit to it, at least given and give some timelines to it. Thank you.
I think we need to come up with some prompts really so that people are clear on what they're committing to, so we can come up with a list of this is what we expect from a pledge and people sign up to it.
It's more about how we can support you, because we can provide information and a lot of it, the evidence that is coming out, but we can't. It's up to different organisations to make those decisions and to commit.
So I think the way that we tend to work well is that this discussion must feed into that summit, which is where those statements of intent and so on will. I'm not sure we can craft that right now, but this discussion will inform that summit. But incredibly valuable. If you're all willing to stay 10 minutes beyond finish time, we'll have this. We have 3 more people to speak. James, then Richard, then Mike.
Thank you.
Well, it's me, is it?
Thank you, Chair. Thank you, Val. Thank you, Jyoti. Thank you, team, for the report. As a jobbing GP, I see every day people whose health, well-being, and indeed lifespan is affected by obesity. It's not just the cardiovascular impacts, it's the joint impacts, it's the increased risks of cancer. And I think this is probably the most important challenge that we face as a health and well-being board, and one that we can address. We have the tools to address it, and it can be dealt with. I think to do that effectively means that we have to avoid stigmatizing obesity. We have to avoid coercion of those who feel marginalized by a campaign. And we have to reduce the barriers to entry to weight loss programs for those who are already obese. And I think most importantly, going back to the school element, I think it's the prevention, the early education, the involvement of children as the agents of social influence on their parents and their broader families that actually, again, collectively, we can address. And just I suppose a slight alarm bell rang in my head when you were talking, Val, about primary care, 74% of people attending once a year, ideal place to do weighing people. If I just did a quick back of the envelope calculation, if we take 2 minutes per adult attending each year, I think it works out at 18 full-time equivalent new employees just to do that, assuming they're at 100% activity. So realistically, it's between £500,000 to £1 million a year just to weigh everyone as an additional activity if we do it in general practice. If we're thinking more broadly, more people go to their supermarket each week than their GP each week. So maybe we should be thinking much more broadly about corporate social responsibility of placing self-weighing stations in supermarkets and other places that people attend, and using that to feed into our service rather than thinking only through the traditional healthcare provider element. So I'll just throw that in as a thought. Thank you.
Yeah. I think one, we wouldn't be, it would be more of a voluntary request for people coming into practices, so it becomes almost routine, and we wouldn't expect any staff to oversee it, but we would want the results going through to the notes, so it aids with the identification of people. I think your point about just focusing on GP practices is well made, but I think you have to have some linkage. People will go into Boots and they might take their blood pressure, but then does that information ever go anywhere? Do I ever do anything with it? So there needs to be some link up between any data that we secure, and then enable, and if it needs follow up, then that can be enabled through linking to GP practices. because otherwise you're just, you know, and I personally would not recommend supermarkets. I think if you're putting them in places where you have staff who are alerted and can encourage people to become weighed, to be weighed. And I've been talking to colleagues in Luton where they have done this, and they've linked up the data to pharmacies, in fact, that have, and then the pharmacies then put the data through the GP practice. So there are different models you can use, but ultimately, you know, if it's going to identify an issue, then it's got to be followed through. But let's say the early work, the lower level stuff could be done in a different way.
Thank you. Richard.
I think it's a really important discussion this. I agreed with a lot Jan said, so I'll speak for slightly shorter, but endorse a couple of points that she made. First of all, about the nature of this discussion, I think Anis was right to say we've got to get out of the culture that there's a brilliantly drawn up strategy that all we have to do is scrutinise it, agree it, and go away and do nothing, and it's somebody else's job to do it. That's not what we're trying to do in the ICS. We're trying to look at the role that we're all playing in this. And so Anis and others who said that in this meeting, I totally agree with that. And perhaps the way we structured the discussion has been very much almost question and answer to the officers rather than a discussion amongst ourselves and then the officers coming back. And I think we've got to think about the way that we deal with things. Secondly, what are we going to do because of it? Is this, the public health team already has brilliant work on healthy eating and anti-obesity, right? This can be even more brilliant following this strategy reformulation. But what are we going to do differently than that other than encourage them and thank them? And if we are serious about the prevention agenda, what are the trust leaders around this table going to do less of so that they can invest? Maybe it's a good investment to do what James says. Maybe that would be a good use of money and it would produce better health outcomes in the long term. I don't know, but it might well do. But where is that being considered? And for the trust leaders, I know the financial pressures you're under, but this is a great acid test on whether we're serious about prevention. And it's not just about nodding it and the public health team will go away and do it. It's about what we as a system are going to do. So I strongly support Anis's suggestions that when we come to the summit, people come along and they've got something to say about that. And let's see if we can make it work. Finally, I will just say this about school meals. I think Jyoti's absolutely right to talk about what's happening across the rest of the country on potential expansion of free school meals, including London, which is really significant. Who's doing any work on the potential for that? And if there are capacity constraints, what we would do about them? Somebody somewhere in the system, even if we can't afford it, and even if it's not going to happen, somebody should at least be considering that, scoping it out. What would the costs be? What would the health benefits be? I do hope that somebody takes ownership of that. And certainly on behalf of Cambridgeshire County Council, in our work with schools, it is damn difficult because there are now so many that are arm's length from the local authority. What Val said is completely right on that. And the other stuff that she sent us recently about, there are so many different providers in the past when it was all statist and education authorities controlled the world and there was one provider. There's obviously disadvantages to that, I'm the first to acknowledge, but the advantage to that is if you want to change the system for health reasons, you could do it. Now it's extremely difficult for us to do that. But I don't think that we should be sitting in this room just complaining about that and moping. I think it's our duty to speak out. Should we be looking at greater free school meal provision? The stuff that we do in Cambridgeshire County Council for extra free school meals in school holidays, I'm deeply proud of. And, can someone notice that and look at the health benefits of that? And maybe we can share that around more widely. And then when I see the government's food strategy, where there've been these constant campaigns nationally about the quality of nutrition in school meals, and there's the Henry Dimbleby review now 3 years old, why don't we join the chorus of people who actually say we want to see that review implemented? We'll do our best to influence that within our own geography, but we'll be part of the national voice that will support that. And the government's current strategy provides a one-off payment of £250 to a school to improve healthy eating. You know, that is a joke. It's a complete joke. And let's not sort of pretend that that isn't part of what we're talking about here, because if the schools aren't resourced to do the right thing for health outcomes, all of our strategies and our encouragement in the world isn't going to work. So it's got to be part of what we talk about. Thank you.
Excellent, thanks. I know I want to respond to, oh, sorry, it's up to, well, actually, I will respond if I may. I mean, it's been a fantastic discussion. Mike, you've put your hand down. However, well, we never did get to hospital concourses and Burger King, which, you know, is actually, I think, one of the headlines here. In terms of messaging, if we're going to be tackling school, if we're going to be tackling, I mean, I think it's agreed at this board that a prevention starts with children at the earliest age, and they are born in hospitals. With Burger King, they could start right away. But it's a serious image issue. And if I'll just while I'm speaking, I think what we could do today, and sorry, Mike, I'll give you come back and well, why don't I hand over to you first, because then I want to say some general.
Well, just on that point, look, the Cambridge University Hospitals Board, I'm sorry, I'm Chair Adam Brooks, is deeply aware of the problem of the image of that. It's a long-standing contract which would take millions of pounds for us to extract from. That's the problem. But it's not something we manage ourselves. It's something which is managed under contract for people who let one of the busiest concourses in UK hospitals. And so it's the financial extraction point. But as a board, absolutely, we recognise the difficulty of that. And there will be opportunities in the coming period to change that. But I do get the point. It's not something that we are kind of entirely free agents in the context of the cost of extraction. But I mean, in terms of the pledge, I mean, the points I was going to make were, it seems to me that there is something, I mean, I think it's really great stuff. Clearly, we see the end result often of obesity in terms of 20-year-olds coming in with chronic obesity-related conditions where, frankly, the quality of the life, indeed the length of their life, is going to be very much foreshortened. So we deal not so much at the prevention end as much, we deal more with dealing with the consequences end. But of course, we would want to be active players in the pledge and active players in what we can contribute to. But I would just say that it's a little bit like, you know, County Council has difficulties in terms of price of school meals and difficulties in terms of the district. We all have complexities. We as hospital aren't going in there with a food course, so it doesn't matter. No, we recognise that.
If I may, I suppose our fast food providers perhaps ought to be partners at this table. There's the menu of what they offer. And I was saying to someone before the meeting started, McDonald's in Taiwan many years ago introduced a healthy menu. So that anyway, food for thought, as they say. I just oh, sorry. Yeah, I don't.
Thank you, Chair. I'll keep it quick. David Packer, Senior Advisor to the Mayor of the Combined Authority, here in substitution for the Mayor. 3 questions. Does, and if not can, the in-school, in-term work extend to holiday activity and food programs provided by the relevant authorities? On free school meals, the challenges you say about managing and accessing the data aside, is it possible to do a geographic analysis of free school meal eligibility and failure to take up, so that perhaps the pockets that were referred to earlier could be right. Fine. And then sorry, and then finally, is there a date set for the summit in the autumn yet, please?
We'd anticipated November. that would be the idea, not a set date. It relies on, I'm currently talking to speakers, so it very much depends on external speakers and their calendars. So, and sometimes that takes a little while to coordinate.
Thanks. Okay, we'll round up in a second. James, do you have a golden nugget to add?
Just very briefly, collectively in this room, I think we probably represent organizations that employ, what, 30 or 40,000 people. Why don't we start with our own organizations? We can weigh everyone in the organizations. We can make a pledge. We can change the food. We can encourage exercise. Why don't we start with the bit directly under our control rather than pontificating about those beyond our control?
Thank you, James. And if there's
That's
so much
absolutely on our list.
Great. And it's not just weighing, is it? It's the exemplar of living healthily. Okay. And I was going to ask, could we add breakfast to the school meal discussion? If you go to a governor's meeting, I think they'll be talking about children who come to school without breakfast, and that influences the rest of their day and what they eat. Okay, it's been a fantastic discussion, and I absolutely, I think there's been some really important challenges. I'm not sure we can. Are you content that we what does it say here? That we agree this report, but that these that are we have sort of a stage 2. The action at this summit needs to be not just noting another report, but taking our challenges today and considering what kinds of pledges we can make. And I think, James, your golden nugget there kind of gives us a helpful starting point, leading by example. So if everyone is content to agree this paper on that basis, and to reiterate thanks to everyone involved. I remember we had a development session in this room last October, and I think the group that was sitting here said we've got to talk about obesity. And here we are. Okay. Yeah, Stuart.
Sorry, Chair, I'm not sure we've covered Jan's point that I thought several of us had agreed with, that why don't we make a pledge now?
The issue is you're not sure what you're pledging to. We haven't documented what the pledge is. So I think we'll take that away and work up some proposals for a pledge.
All right. We have gone about 20 minutes over, but I think that was very worthwhile. And we will move. Everyone content to move on to the next item, which is number 5, the joint forward plan for the integrated care board. Yeah. Jan, over to you. Thanks.
Thanks, Chair. And I think we should be able to catch up some time, hopefully. I'm also relieved to be able to breathe out again, because after talking about obesity, does anybody else sit there and hold themselves in for the whole conversation? There has been a huge amount of engagement on this. We did a development session on this a few weeks ago. In front of you, I will take it as read, which is the joint forward plan summary. That is a requirement of the integrated care board to submit, which effectively gives its forward look at its priorities and commitments. This plan for us goes a little bit further in that we have delivery plans sitting behind this, and we are just further refining those based on feedback that we have been given across all of the wider stakeholder engagement. We hope that this is a familiar document to people, and we have made significant changes from that last development session in it, and I hope that's reflected in the comments that you've got. So I think I can leave it there and take that report as read.
Thank you, Jan. Would anybody like to comment or ask any questions? No. Okay. Well, I was going to say thank you very much, because we had an absolutely brilliant development session. Richard's going to come in. Over to you.
it's a really tangential point, but you've got to take your opportunities in this game. And on the section of mental health and learning disabilities, it just prompts me a conversation I had recently with our public health colleagues. There's been a really interesting piece of work done on health needs assessment for people with learning disabilities. And I'm not quite sure how that's being dealt with in the ICS. But one, it's good for me to make this everyone in the room aware that that work's been done. And two, can I ask just Jan for you to look and see how that can be best used within the ICS?
Yes, certainly. We will make sure that we'll come back actually to the group to say how that work has been reflected in this document. I do think, Richard, you also make a really good point about learning disabilities. It is a really, really vulnerable bit of our population, and we know through something that we call the leader, which is learning from deaths of people with learning disabilities, that there are still some really big fundamental issues in there with people not necessarily getting the care, the support, or knowing how to access help when they need it, that they do. So it is really particularly important that when we're looking at this forward plan, we don't just concentrate on what we would usually think as the big things, as in activity, hospital work, etc., but really focus on those most vulnerable. And I think it would be really worthwhile at some point in the future if we together considered what if we were doing enough for populations, not just mental health, but specifically learning disabilities.
Thank you. A question from Mary Elford on the screen there. Thanks.
Thank you. Just really to, as a mother of a young woman with a learning disability, everything Jan said really chimes. And I don't know to what extent it's rolled out across wider members of the ICS, but certainly in our trust now, the Oliver McGowan training is mandatory. And I did it myself recently, and I can't recommend that training highly enough. I think it is being rolled out across the NHS, but I don't know if it is available to local authority and voluntary sector colleagues, but it really is an excellent piece of training that was developed with a mother whose son died. An unavoidable death within a hospital, but it's a lot of the participants have got learning disabilities, and their own experiences that they relay are very, very powerful. It's one of the best bits of training I've done.
So anybody who doesn't know about the training or would like to access it for their organisation that they don't, please get in contact with us, because it is honestly, it is the single best lot of training I have done. It is mandatory for us and all of our staff, and I would absolutely encourage anybody who hasn't done it to participate. If you can't access it directly for any reason, I would be very willing to get our learning disabilities team and others to do some training directly with different members of partner organisations, if that would be helpful.
Thank you, Jan. I wonder if that could just be circulated straight off. Thank you. Okay, and I think I just wanted to note that the recommendation in the joint forward plan we did work in a statement about accountability. And I'm looking at you, Denise, that we aren't just saying what we've done, but that we are accountable for our ambitions. And we also talked about the realities, the hard realities that we face against the necessity to be ambitious. So I was very glad to see that expressed. And I think that the final report is a bit more expansive in as much as it can be about dentistry, one of the great challenges. So again, thank you for the inputs to the final paper following our development session. I don't know if Jan, do you need to comment further or no? Okay, well then with that, we will thank you very much for this joint forward plan, the first time we've ever encountered it, speaking as councillors. And okay, no objections. So we're moving on to the next one, which is after reading? No. Okay, I think we're moving on to the Better Care Fund now. Yeah, so our final main piece today is the Cambridgeshire and Peterborough Better Care Fund Plan 2023 to 25 and the end of year 2022-23 returns report. And I'd like to invite Caroline Townsend, Better Care Fund Project Lead, to present. Thank you.
Thank you, Chair. I won't be as effective, I'm sure, of making up time as Jan was there, but I'll do my best to keep it short in terms of overview. I'm conscious we also had a very detailed and well attended engagement development session on the Better Care Fund earlier in June, which fed into the Better Care Fund plan submission. The overview report, as it lays out, is that we're coming for approval for 2 items today. The first is the end of year submissions for 22-23, which were submitted back in May, and the second is the local plans for the Better Care Fund for 2023 through to 2025, which was submitted to NHS England at the end of June. Both of those were submitted in line with the national deadlines because there was no flexibility on them. However, they have been submitted with the caveat that they are pending full approval with the Health and Wellbeing Board, and we will be feeding back after this meeting in terms of the discussion today. And obviously, if there are any amendments or changes, there is the ability to make those changes. Just in terms of kind of key summary points really to draw out, in terms of the end of year reports, they provide a very high level summary position, both in terms of our performance metrics and our financial position. Overall, in terms of performance, our performance improved quite substantially this year, and we had relatively good performance for most of our metrics. Pretty much for all of them for both Peterborough and Cambridgeshire, except residential admissions did remain slightly challenged in the Peterborough, which is something that we are aware about and is an area that we do continue to look at. We didn't see any changes in terms of planned financial spend, but there was a key shift in terms of the Adult Social Care Discharge Fund last year, which was a new grant allocation that was awarded to both the ICB and the local authority at the end of last year, with a requirement that that be brought into the Better Care Fund pooled budget. So the end of year report does contain those allocations and quite detailed breakdown of expenditure plan and some of the outputs that delivered. That was the key sort of financial change in terms of any of the financials. And you will see as well that it does give kind of high level summary in terms of a couple of sort of key successes and challenges that we experienced as a system throughout last financial year. In terms of the plan for 23 to 25, as outlined and sort of discussed very much with the development session that fed into that, it's very much been around building on the learning and the journey to date, very much around refreshing our integration vision and our strategic themes and shaping them in terms of our direction of travel, particularly around place and integrated neighbourhoods, and recognising that they really are a core foundation in terms of what we want to deliver around integration. So very much some of the strategic themes are very much around prevention and early intervention, you know, actually how we continue to support people to remain safe, well, healthy in their own communities, but also recognising that when people do need support, that we do that in an integrated and holistic way and in a personalised way. And equally, when people reach crisis, we try to prevent them unnecessarily going into hospital. We have that crisis response, but when people do go to hospital, we have the pathways and the support to get them home and discharge them safely. And obviously, there are a number of enabler functions that support us to do that. So that's kind of the framing with place and integrated neighbourhoods really being key to kind of how we model and deliver those pathways. we very much committed as a system, recognising that we've got a real opportunity in terms of where we are with the Better Care Fund now that we're having this discussion so much earlier on in the year, and we've now got a 2-year planning cycle, which is a really great and refreshing place to be. This is actually really early on for the guidance, etc., to come out, and with a 2-year planning cycle, it gives us this opportunity to be a lot more forward thinking as a system, and we're very committed as a system to do an evaluation of the BCF to make sure that we are continuing to be focused in the right areas, that we've got the investments in the right places, and we're delivering the best outcomes, and delivering against the priorities that we need to effectively have the impact that we want to be having, and understanding where our gaps are, and understanding if we need to look at kind of shifting some of that or changing some of the ways that we're delivering things, and where our opportunities are going forward. We have had some discussions with NHS England just on 2 counts. So in terms of the content of our plan submission, we've had some really positive feedback. So they're very impressed with the content of the plan, and the way that it's very clearly articulating what is obviously very complex across a very complex system. And we are one of only 2 areas where we have successfully managed to articulate all of the key criteria without them having to come back to us and ask for that. So we haven't got any concerns around plans being formally approved. And on a second note, NHS England do have a BCF support offer available, which is free of charge to the system. And we've had some initial discussions around their support offer and how they might be able to support us locally with the evaluation piece, which they are very keen to come in. And I would certainly really welcome views from the board around whether it's felt that independent kind of view and involvement would be helpful to us to do that and drive that evaluation forward. Just on a formal note, wanted it to be noticed, I did have some feedback just post the submission going in from the combined authority. So I just wanted to note it for the board that following the board today, I will be making just an amendment to the plan to formally note down that combined authority is a partner who is actively involved in the system and in the Better Care Fund plan. So I did want to just make that noted for the board. And I'll stop there and take feedback and comments and questions.
Thank you very much, Caroline. Are there questions, comments from around the table? Richard.
People are too quiet. I think we've got stuck in a rut with the Better Care Fund reporting because the deadlines the government gives us are so tight that we have excellent officers like Caroline and her colleagues who do a brilliant job, and this is all great stuff in the report, but essentially it's about retrospectively providing a lot of information to make sure that we're jumping through the government's hoops and we get the money, and we all need the money, let's face it. So I don't criticize that at all, but what Caroline said in her presentation, that at last we've got a chance to look forward rather than look back, is really important. I'm sorry I wasn't in the development session, and my colleague Councillor Goodliff was there, but I understand it was very good, and thank you for taking part in taking the comments on board in these papers. But I just would want to signal to other partners here, let's do some forward thinking. We've got a bit of time and space, we've got to fill in these forms by this month and all the rest of it, but actually we've got an invitation to do a forward 2-year strategy on this. And as difficult as it all is for all of us because we haven't got enough money, here's some money, right? So here's an opportunity to take something that we've all got an incentive to deal with and to think how we might use it productively within the spirit of the strategy that we talk about in these meetings. And I've got an open mind about it, to be honest, but I do see it as an opportunity. So I certainly, on behalf of Cambridgeshire County Council, we would like to talk with other system partners about this in private and informal meetings, between now and October, and let's just have some thoughts about whether we want to build on the discussion that took place in the development session and better marry the use of the Better Care Fund with our objectives. So that's an invitation from us to others around the table if there is an interest in that.
Thank you, Richard. Can I go on to John?
So I agree with Richard. We should take the opportunity, and I think that is an advantage of the fact that we've got the slightly longer horizon now going forward. And I note, Caroline, in the paper we talked about the systematic review, with partners, and I guess just sort of trying to clarify whether we can do some of that over the next coming months, and then use that actively in this session in October would be a really good outcome. And it might shape your question, or the answer to your question, about sort of how we use that possible additional resource, nationally, in terms of helping us with that, or at least checking and challenging what we come up with. So I think it'd be good to form an action around that today.
Thank you, Caroline. Did you want to come back?
Yes, absolutely. I think we've got a commitment to come back in October, and it would be good to have that further discussion in terms of progress of work around doing the evaluation between now and then. Conversations with the support team have indicated that their support offer is also an open offer. So it's not we'll just do one thing and then that's it, we'll leave you. It's actually, we can do some support now. We can also, if there's further opportunities, we can come in and look at more things, etc. So there's a rolling kind of program of support offer. We are happy to kind of follow up and do some scoping with them. We've had some initial conversations to say, actually, high level, we'd quite like to sort of have a look at doing a bit of a understanding around sort of logic modeling, in terms of actually can we do some work around looking at the impact that some of the investment areas are having, actually where do we think some gap analysis, where do we think some of our gaps are, etc. So, and as an opportunity to help us with the initial piece, and then I think there may be some further areas that come out of that where we actually go, do you know what, we might have some big gaps that we've identified that we want to do some bigger digging in, etc. And there may be opportunities for them to also do some further work with us as we go forward too. So they do have an ongoing rolling programme year on year, so they do have an open door. Yes, absolutely, really happy to come back in October. You can come update where we're at, have an open discussion, and I think that would be really welcome.
Thank you. Jan.
So I just to answer your specific question on the independent review and support, I would certainly back that. I think Kate and Pam next to you from our colleagues from the ICBU would agree with that and move that forward. So personally, I would welcome if we could agree that as a partnership. Secondly, look, we have to think very, very differently longer term, and Richard's point and John's points are right. If we keep doing this reactive year on year, we're not going to create the change to the pathways we need to cope with the volumes that we know is not just happening now, but is going to keep growing with the increasing burden of frailty in our residents. So this isn't a nice to do. This is an absolutely core to keeping people as safe and well in their own homes as possible. For as long as possible. And I think, Mike, you and I would agree when we say, hospitals are not good places to be, and the purpose of this fund and other areas where we are working together on is to try and avoid people ending up in those environments and then not able to be in their own home, which is a much better place for them. So we have to be quite I think strategic about this. We also have to be very transparent in saying not just what we're doing with this, but when we get new monies in, how are we making sure that is solving some of the problems we're being asked to solve, because we all have a long list of other problems, don't we? And I know it's very tempting for us to look at ways to solve multiple problems, but when we get into the crush of winter, we must be very clear of what we've got and how we're trying to use it. So we must get strategic, but any short wins we get, we must apply it correctly and make sure we're getting the best use out of it. And yes, please, to the external scrutiny.
Thanks. Julie Farrell.
Thank you. Thanks very much, Caroline. I really enjoyed reading the report, and the option now to actually be able to influence things in the future is really, really helpful. And Richard's point revolving around having further discussions also really helpful. I want to make a point that you very clearly demonstrate in your report about the fact that the voluntary sector is a wide and delivers lots of things, and therefore the data that it provides cannot be assessed in the same way as other data within the system. I just want to reassure you that the Health Alliance is working on that fact and is actually pulling together similar data, that the data is collected across all the parts of the system. And my hope is in the next couple of months, we'll have something that will be able to align more with what data you already collect, which I think will give you a different dimension and enable us to actually identify things and maybe really be able to focus down on what is the voluntary sector doing to support the system and how and what more can it do. So it's just a bit of reassurance to the Health and Wellbeing Board that the broader Health Alliance is doing quite a lot of work on the data collection, because we see it as a key piece and it's a missing piece for the sector. We've always done things in isolation, but working collectively, we now know we need to be able to feed in a different way.
Oh, can I?
Yes,
oh,
yes.
sorry. Thank you, Julie. I really welcome hearing that. And obviously, I know there's a lot of work going on with the VCS Alliance. And I suppose just to add to that, I recognise that data isn't just an issue in terms of the voluntary sector as well. And I think it's something that we've certainly started to experience, even probably slightly more acutely over the last kind of 12 months with the BCF, as there's been some more demands from NHS England linked with the Better Care Fund around reporting, and actually some of the way that social care, for instance, records our data. Although we have hugely comprehensive systems that we record data, it doesn't necessarily, the way we record data isn't necessarily recorded in a way that is naturally fits with the NHS systems and pathways. So actually we have, you know, we have some of those issues kind of wider than with just the voluntary sector. But I think that's, you know, we recognise as a system that is a piece that we need to work through, and it's, you know, and it's really welcome to hear. And I know the VCS Alliance is a really big piece of work around the discharge, single discharge pathway as well. So brilliant. Thank you.
Thank you. Patrick.
Yeah, thanks, Chair. I think it's a great piece of work by Caroline and the team, you know, both to complete it in the tight timescales, but also the feedback that we've received for it. But we have to realise this is just money. It's just a funding stream. What it does is it provides a vehicle for creative use of that funding. And I think the point that Jan makes is about the potential of the system to work more integrated and more creatively to solve this deep underlying problems of where we need to focus. We kind of get distracted by the hoops that we have to jump through the Better Care Fund rather than actually trying to solve as a system the real challenges that we face. The Better Care Fund is just one funding stream that enables us to do that. And I think we're often drawn into, oh, we must do this around the Better Care Fund, and appreciate we have to do that. But I think there's a greater opportunity for us as a system to think how we work integrated. The vehicle of the ICP, the ICS, our partners, including the voluntary sector, are about how do we really work differently and think differently around tackling some of the major problems. The funding will always come, be it through other routes or through the Better Care Fund. It's just a vehicle, and I think if we think of it as just another funding stream, it helps with our focus to be more on the challenges that we face rather than how do we account for it.
If I may chime in, I wanted to say similarly that, I mean, even the presentation of the report is prescribed, isn't it? The format of it. And a layperson looking at it will think, you know, I can't it's hard to make sense of, but in fact, it is about where we sit together in an integrated as a system. I did want to say, just as a councillor, we do come into contact with the Disabled Facilities Grant all the time. People get in touch. They need to access that money in order to stay at home independently. And we know that that fund has not risen, has it? I believe that was one comment. And then the other one was, and this is where the integration sits, is the role that OTs, occupational therapists, play in allowing that grant to be delivered for an individual. Caroline.
Yes, so this year, in terms of the Disabled Facilities Grant, it has remained, the funding has remained at the same level. There hasn't been any increase in terms of that. However, the government has committed to an additional £100 million worth of disabled facilities funding, and so we are expecting increases in disabled facilities grant funding, but those allocations haven't been announced yet, so we don't know what that translates to in terms of local allocations. We do expect that will come down separately to the Better Care Fund, because I think that's probably just resulted as a timing thing, that they haven't managed to sort out the allocations, and they didn't want to delay the Better Care Fund, so they've kept it as a separate thing. So we are waiting on those allocations. They are prescribed allocations, and obviously they do passport through to the districts, but once we know those, we are expecting some additional monies to go into the districts, which I think will be very welcome, because we do recognise that there have been sort of continuing pressures on the Disabled Facilities Grant. In respect of OTs, yes, so generally the pathway into applying for a Disabled Facilities Grant would be that someone would have an OT assessment, which would identify the need for certain adaptations, etc., to be made to property, and then that would go through to the districts to process a Disabled Facilities Grant application. The reality is, as we know, that we do have continued challenges around workforce, and occupational therapy is one of those areas where which are particularly challenged, and as a result there can be waiting lists. I'm not sure what the current position is around waiting lists at the moment for OTs, but it is an area that we do know is a focus, and certainly from a social care perspective, it's one of the areas that we are very focused on in terms of our workforce development programme, and looking at how we can really kind of target that area, and how we can also look at trying to build the sort of skills more flexibly in terms of OTs as well, because quite often OTs can be quite specialist in their areas, which makes it quite difficult to recruit and utilise them flexibly across different areas. What I would also say is we've some of the funding, some of the additionality of discharge funding that we had in the Better Care Fund this year from the local authorities fund, discharge funding, we have also allocated towards doing some workforce development, which is going to be targeted more around discharge elements, but it is going to be targeted on some of the areas where we know workforce is needed to support discharge. So OTs are obviously quite a crucial element of discharge too. So there will be some slightly different focus, I know, but there will be looking at OTs within that area as well. So there is some more funding going into that area. So I don't know if that answers everything, Susan.
Yeah, if I'm so on that, thank you. I mean, certainly that's sort of debate about what we call allied health professionals in the overall picture is something that we've been looking at. We introduced a very senior leader of allied health professionals 2 or 3 years ago in the hospital. This is Adam Brooks. For the reasons you say, that actually that it's not just doctors and nurses. The allied health professionals and readying people to be able to return to their home, etc., or other places is fundamental to things like flow through hospitals, etc. And some of the data would suggest that investment makes sense. We've been certainly having lots of discussions in that. I don't think we've got to settle position on it, but I think, and certainly some of the evidence. So I think if there were viewpoints that to contribute to the way we think about that, I would be very much open to that.
I definitely think that there are opportunities where health and social care, because could link up more around some of our workforce initiatives, and I think we are having discussions and making some of those links. But I do think we could.
Thank you. Yeah, no, thank you for that. I think that feeds into a continuing discussion and concern around workforce across health and social care. So that's very timely. And I don't think we've touched on neighborhood place as it sits in this in these pages, but ultimately we are focused, aren't we, on development of our integrated neighborhoods, as we call them. So I'm just looking at our officers when we meet in October. I don't see this on the well, we're going to get to the agenda plan in a minute, but we've talked about being able to look more strategically at our next meeting, and I think we've identified some themes here that we want to make sure we're resting our discussion on, rather than the technicalities of what's coming and when. Jyoti, do you want to?
Yeah, absolutely understood. We'll program that in.
Okay, so are you all happy to approve the two plans, the 2023-25 Better Care Fund plans and the end year report for the 22-23? Yep. Okay, good. And amazing. We are going to finish possibly early. We just have now the forward agenda plan. And we've just had a discussion about that. And I think it lists the priority, the discussion on one of our priorities. And the discussion today on the obesity paper was, I thought, outstanding. And we actually did get into the structural issues. I didn't know that the hospital concourse was tied into that contract, stuff like that, the local plans. So I'm sure we'll have another very good discussion in October. I don't know if we know what that will be next, but
I think we might focus it on the addressing poverty priority.
Thank you. And then just to draw your attention, you may have had a diary invitation. Our next meeting, which is the 20th of October, we're looking at having a development session on the same day. So we would have the morning or the afternoon, one or the other. It's not confirmed yet, but please could you hold it in your diaries? There will be no cake. There may be bananas, I think. And with that, oh, sorry, Mike.
Chair, so I know I've said somewhere this, but I can't remember where, so forgive me. I can no longer attend on Fridays from September. So I think we'll need to find an alternative person to represent the Acute Trust. It's just I'm unable to do Fridays anymore. I think I indicated that last time, but yeah.
We may move to another day of the week. Just kidding. Stuart. Yep.
Thank you, Chair. If I could just have 15 seconds. Summits are a bit like buses to come along at the same, with apologies to the Mayor's advisor, to come along at the same time. Could I just give a plug to the Health Watch Summit, which takes place on the 11th of October, and there'll be real people there, people who go to hospitals, are in receipt of care, who sit on our partnership boards and come to our forums. They will be there, as well as those who deliver the services, and quite a number of people who make the decisions about those services. And one or two of the speakers at the conference might well be sitting around this table at the moment, and there'll be some other, hopefully, national speakers to join us as well. This year, it's called Social Care Meeting the Challenges, which I guess you could interpret both ways: those who are working in social care meeting the challenges, and those who are in receipt of local care, as we've discussed. You can sign up on the website. I'm pleased to say we opened bookings a week ago and already 150 people have signed up for it. So it's going to be good. 11th of October, Kingsgate Centre in Peterborough. It was longer than 15 seconds. Thank you.
Thank you very much. I did forget to ask if there was any other business. Anybody else? No. All right, then I declare the meeting closed. Thank you very much for attending.